My name is David Ficker, and I will be moderating today's webinar. I'm Professor of Neurology at the University of Cincinnati Gardner Neuroscience Institute and Associate Director of the Epilepsy Center. I chair the AES Webinar Work Group and am the Chair-elect of the Epilepsy Foundation Professional Advisory Board. My disclosures are the following: Greenwich Biosciences speaker and Best Doctors consultant. Today's webinar features presentations from providers who will review evidence in support of patient self-management in epilepsy, describe programs that are currently available virtually, including HOBSCOTCH, UPLIFT, PACES, and SMART, and describe immediate opportunities and support for implementing these programs in the clinical setting. Before we get started, I would like to take a moment to acquaint you with how we will send questions in the Zoom technology. At the bottom of your screen, you will see the Q&A button. To submit a question, please type your question in the small text box at the bottom, and when finished, click the send button. We will try to respond to as many questions as possible during today's presentation. As I introduce the speakers, we will put up a quick poll question, and we would like to know how you were involved in epilepsy care and what is your background. So there we go. We are joined today by several speakers and panelists. All speakers will present, and then we will have time for questions and a panel discussion. Our speakers today include Dr. Robert Frazier, who is professor in the University of Washington's Department of Rehabilitation Medicine, joint with the Departments of Neurological Surgery and Neurology, and consultant with Associates in Rehabilitation and Neuropsychology. He is an active counseling and rehabilitation psychologist, a certified rehabilitation counselor, and a certified life planner who directs neurological vocational services within rehabilitation medicine. Within neurologic rehabilitation, he has specialized in epilepsy, brain injury, and multiple sclerosis. Dr. Frazier is a co-investigator with Dr. Johnson on PACES in epilepsy, a CDC-funded epilepsy self-management treatment program for adults. He has indicated he has no financial relationships to disclose relevant to this activity. Dr. Barbara Jobst is currently the Lewis and Ruth Frank Professor of Neurosciences at the Geisel School of Medicine at Dartmouth, Vice Chair of Neurology at Dartmouth Hitchcock Medical Center, and co-director of the Dartmouth Hitchcock Epilepsy Center. She has coordinated the Managing Epilepsy Well Network, one of the thematic research networks of the Centers for Disease Control and Prevention, which aims to improve the quality of life of patients with epilepsy through self-management. Under her leadership, a team of researchers at Dartmouth developed and tested the HOBSCOTCH program to address cognitive impairment in adults with epilepsy. She is also on the editorial board of Neurology and Epilepsia and is active in multiple professional societies. She has the following disclosures: research support from NeuroPace, Medtronic, Harvard Pilgrim, NIH, CDC, NSF, DARPA, and is associate editor of Neurology. Dr. Erica Johnson is a rehabilitation psychologist and a certified rehabilitation counselor as well as a fellow of the American Epilepsy Society. She is co-investigator with Dr. Frazier on PACES in epilepsy, a CDC-funded epilepsy self-management treatment program for adults. In addition to her work on PACES, she is a principal investigator and training director for Project UPLIFT, a program to prevent and treat depression in adults with epilepsy. Outside of her research program, she's in private practice in Linwood, Washington, where she conducts psychosocial and neuropsychological assessments and therapy. She has no financial relationships to disclose relevant to this activity. Dr. Martha Sajatovic is professor of psychiatry and neurology at Case Western Reserve University School of Medicine in Cleveland, Ohio. She is a researcher, education, and clinician who has devoted herself to the study and treatment of the traditionally hard-to-treat populations with CNS disorders. She holds the Willard Brown Chair in Neurological Outcomes at the University Hospitals Cleveland Medical Case Western Reserve University School of Medicine and has subspecialty certification in behavioral neurology and neuropsychiatry. She is the principal investigator of the MU program SMART in epilepsy. She has no financial relationships to disclose to this activity. And then we also are joined by two panelists, Dr. Elaine Karakopoulos, who is Assistant Professor of Neurology at the Geisel School of Medicine at Dartmouth College and co-director of the HOBSCOTCH Initiative at the Dartmouth-Hitchcock Epilepsy Center. She previously served as Harvard Medical Faculty Physician in the Comprehensive Epilepsy Center at the Beth Israel Deaconess Medical Center, combining clinical neurology practice and research. She most recently served as the Epilepsy Foundation's National Director of Health Communications and Engagement, focusing on accessible health education and improving systems of care for people living with epilepsy. At the HOBSCOTCH Institute, with the guidance of Dr. Barbara Yost, her efforts will aim to expand epilepsy self-management education, program adoption, and delivery and research. She has no financial relationships to disclose. And then finally, Samantha Schmidt is the project coordinator for the Managing Epilepsy Well network. Samantha supports the National Mu Network and operates from Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire, under the guidance of the network PIs, Dr. Barbara Yost and Dr. Cam S. Coffery. Prior to her role as the project coordinator, she was the coordinator of the HOBSCOTCH Phase 2 clinical trial, which evaluated self-management program at 4 centers in northern New England. She is a member of the American Epilepsy Society and the American Academy of Neurology. She has no financial relationships to disclose. If we can have the slide with the learning objectives. So our learning objectives today are to first describe the evidence supporting the benefits of epilepsy-based self-management programs, identify current epilepsy self-management programs that are currently in place, identify pathways for patient referral to programs and training opportunities available to epilepsy center team members. Before I turn the presentation over to Dr. Barbara Yost, I want to give a special thanks to all of the speakers for preparing this talk on short notice, really within a week's time, and AES staff for putting this together as well to provide information to our members on self-management programs for epilepsy. Dr. Yost.
Hello, thank you for that introduction, and I want to also thank you for taking the time to be on this webinar at these difficult times of COVID, and I hope you're all staying safe and holding up well. We thought this is a very timely time to really talk about epilepsy self-management, because for our patients these times are certainly also very difficult, and we want to present some programs of the Managing Epilepsy Well network. Can you go to the next slide? And we want to kind of also direct you to our webpage, which is just if you type in Managing Epilepsy, Manage Epilepsy Well, you can also get more information about the programs. Next slide, please. If we are talking about self-management, what is really self-management and what are self-management programs? And the Managing Epilepsy Well network has made it its task to study those. It's really a process to not only control seizures, but also manage as a patient the effects of epilepsy that can regard to any aspect, medication or treatment, seizures, and lifestyle management. And there in other chronic models, other chronic diseases, there are well-established self-management programs, and our current approaches are derived from those. And it really requires a partnership between the person with epilepsy, the provider, and also the family and the support, and does certainly not replace clinical treatment or clinical guidance. Whatever we do should be grounded in behavioral science approaches, and the programs we are talking about have been developed, tested, and implemented by the Mu Network and its partners. Next slide. And all the programs we are talking about actually do have randomized controlled evidence, and were developed within the Managing Epilepsy Well network, who has made it its mission to really advance the science related to epilepsy self-management by facilitating and implementing the research, conducting the research in collaboration with the network, and also involve community stakeholders to broadly disseminate those programs. And we are thankful to the AES today for giving us this opportunity to help with dissemination and implementation. Next slide, please. These are the current research centers involved into the network, and we want to thank the CDC for funding this. Next slide, please. There are currently 5 collaborating centers, 3 partnering centers, but we are also really proud to work with community organizations for dissemination of these evidence-based programs. Next slide. Just how effective is what we do, and this is a recently published study for all or for a certain number of those self-management programs, of which we're going to talk about, HOBSCOTCH, PACES, UPLIFT, any of those. And this is an aggregate study just looking on the effects of self-management on depression, as you see here, as measured with the PHQ-9. These were data from 5 prospective randomized controlled trials, and you see clearly that an intervention with self-management program has an effect on depression. Next slide. And also, we really want to thank our community partners. There was some implementation work with the Epilepsy Foundation. And also what I want to also say here, there are multiple self-management programs available. Also in other countries, we are just presenting 4 here today, but there are also other approaches that may certainly be as effective as the ones presented today. And next slide. With this, I think we want to hand this over to Bob and Erica to talk about PACES.
Yeah, well, good morning, everyone. I'm delighted that you could all be online for this. I'm going to get things rolling, and then I'll have Erica jump in and do the second half. So PACES stands for the Program of Active Consumer Engagement in Epilepsy Self-Management. What is PACES? PACES is an 8-session epilepsy self-management program developed with direct input from adults with epilepsy and subject to RCT evaluation with funding from the Center for Disease Control and Prevention. Next. But to do this, to develop this program, we did the direct mail extensive survey, actually of 258 adults with epilepsy, and had a very good 61% response rate with nice reliability in the ratings. They identified their areas of adjustment concern and also how they would want an epilepsy self-management program delivered. And so based upon the response, we also noted a relatively high level of mood concerns, specifically depression, anxiety also, but depression, about 2/5 of the responders noted moderate level of depression, and then attention and memory concerns were also prevalent. Next slide. So the meat of the program here is our 8 sessions, and the sessions include the following topics: epilepsy and medical issues, which is really almost the current Epilepsy 101, better understanding of epilepsy as a disease, disability, medications, epilepsy management and treatment considerations. The sessions 2 and 3 really deal with anxiety and depression, termed here stress and the blues. And the focus really is on cognitive behavioral therapy strategies that we can teach and people can implement easily. And we kind of follow their progress in goal setting across these 2 areas throughout the remaining sessions. The next one is compensating for cognitive challenges. Again, specifically memory, attention, and to a degree, accommodation strategies related to processing speed. And we give good resources here, including the West Virginia Research and Training Center on accommodations that they can contact at no cost. The next one is getting the most out of community living. We noticed a lot of isolation and depression, and this is getting people more involved in their community in different satisfying activities, volunteerism on a budget. The next one is managing my epilepsy care, which is really working with your doctor and epilepsy organizations. Effective communication about epilepsy is really developing, the core of this is developing your self-disclosure script. And this gets one of the highest ratings of our sessions, and it still surprises us how poorly people are able to describe epilepsy or their particular epilepsy, seizure type, etc., and what to do about it. And finally, my health and well-being, and this is kind of a general well-being kind of a session, but there's a big focus on sleep, which is so important in relation to epilepsy or any disability, nutrition and physical exercise. Next slide. So what are the key delivery elements? It's a tandem facilitator team, which of course is the Kate Lorig model, but it's also what the surveyed participants wanted. They wanted a trained professional with epilepsy leading with a trained peer who also had the disability. The mode of delivery involves an educational component, and then we work with the participants to help them developing coping strategies, work through different exercises in the session, and then each session ends with goal setting. In terms of delivery method and participants' choice, we have on-site, we have telephone conference, and potentially new web-based or Skype options. The telephone conference seems to be most accessible for most participants, and the effectiveness is equal with telephone versus on-site. Well, we added one more thing. It's not on the slide here, but we had boosterism. So we had booster contacts for every 6 to 7 weeks or so throughout the year following the delivery of the program, and that was subcontracted to the local Epilepsy Foundation. Next slide. In terms of effectiveness, one thing is there was very little attrition, only an 8% dropout rate over the 8 weeks. And at 1 year, subjects had significantly better epilepsy self-management strategies, epilepsy self-efficacy, an overall composite score in terms of a better well-being. But in terms of epilepsy self-management specifically, they were significantly better than the controls on information management and lifestyle management. And interestingly enough, the relationship got more significant versus controls over time. So it appears that learned behaviors get traction and people do better. So I'll flip this over to Erica now.
Thanks, Bob. So some additional information that we want to highlight is that along with tracking outcomes in our randomized controlled trial studies, with our efforts at dissemination through EF affiliates in Texas, Michigan, and the Northwest area, we're tracking program information. And here in front of you, you see the ratings. These are comprehensive from all participants who've come into the programs, led by the trained epilepsy professional and trained peer tandem at each of these affiliates. And the highlight here really is that the ratings are high. This is on a 5-point scale, and we're seeing good average ratings for satisfaction with different program elements like the timing, day of the week, the format. Notably for Bob and myself as researchers, the leadership dyad is very highly rated in addition to the topic and content area coverage. Next slide, please. And just in terms of qualitative feedback, we are so fortunate to get input from participants, and it comes in a way that underscores the emotional connection that participants seem to form in the group and the value that they get in terms of the instruction through a group delivery format, whether over the phone or in person. We really get the same feedback that a lot of times this is the first time that these individuals with epilepsy have met other people with epilepsy and are really able to form friendships even in a phone-based milieu. And so we have a quote here from one of our participants saying, "It was really refreshing to talk with others who have epilepsy. Hearing their stories and struggles helped understand mine." So you really get the point here that there's the instructive piece, the education piece, but also a support element. Next slide, please. In terms of where we're headed on a research basis, we are developing PACES for Spanish-speaking populations with adults through the University of Texas Southwestern. We will be in the next year to 2 years adapting PACEs for adolescents, and this will be through Seattle Children's initially, and then also through UCLA with a Spanish version. Next slide, please. I think that in terms of launching PACEs, if you're interested in knowing more about how to bring PACEs to your center, training is a 4-hour time commitment. There is facilitator time involved in terms of recruiting patients, screening them, collecting intervention measures so that, again, we can continue to track outcomes, and you might estimate or budget about 15 hours per group. And then we provide technical assistance from the University of Washington, both for getting started and preparing to launch the program, as well as for ongoing problem solving and support. In terms of why might your center think about utilizing PACEs, we really want to emphasize that this provides a cost-efficient approach to serve the whole person with epilepsy. It really can profile your epilepsy center as being committed to the range of a patient's adjustment concerns, and potentially is something that can be funded, particularly now in this age of coronavirus with the social distancing requirements and the easing of requirements around telehealth and even phone-based healthcare delivery is something that can be safely pursued for our patients. Next slide, please. Okay, and I think that's it for PACEs. I get the pleasure too of speaking to you all this morning about another one of our Managing Epilepsy Well programs, and this is Project UPLIFT. And UPLIFT stands for Using Practice and Learning to Increase Favorable Thoughts. Next slide, please. Project UPLIFT was developed initially as a mindfulness-based cognitive therapy intervention to treat depression in adults with epilepsy. And when we're talking about MBCT, this refers to combining mindfulness and cognitive behavioral therapy. So we think about CBT or cognitive therapy as changing people's thought content. With the addition of a mindfulness component, there's really this idea around a purposeful focus on attention in the present moment without judging it as good or bad. And there's some thinking that this influence or emphasis on mindfulness also allows for a certain amount of change to happen within individuals around their mood, that it's helpful to attend to thoughts without necessarily trying to change them overtly, that this is also important. And so in trying to imagine how this is embodied in an epilepsy self-management program, the sessions involve skills practice. It involves discussion and group exercise based on each session's main topics. And these topics include things like thought monitoring, identifying cognitive distortions, so the way that our thinking might be distorted or off track, self-esteem, problem identification, goal setting, and also identifying supports. In addition, participants are taught strategies like relaxation exercises, including a body scan and a progressive muscle relaxation exercise, which helps with coping and to facilitate awareness of the body. Mindfulness-based activities include attention to breath, sights, and sounds, and other forms of meditations. And the idea with the program is that participants practice their skills between sessions through homework assignments, including monitoring their thoughts, changing thoughts, and practicing relaxation exercises, meditation exercises, and mindfulness. This is a distance-delivered platform, so the way that it's been researched and the most supportive evidence shows that UPLIFT is effective either as a teleconference style group intervention It's also been equally effective in studies as an asynchronous web-based platform, but because of some of the challenges with making the program very accessible, it's been most popularly disseminated via teleconference. And when we're talking about group-based, we're talking about groups of around 6 to 8 people, really not having more than 8 people in a group at a time. And these are what we would call closed groups, meaning people come in and they experience all 8 of the sessions together in the same group composition. It's not kind of an open door format the way you might see with support groups. Next slide, please. In terms of the research base behind UPLIFT and what we know about outcomes, as Dr. Jobst had so nicely articulated at the outset, all of our programs have had the benefit of study through randomized controlled trial. And here, the findings in the slide really highlight 3 different studies, all of which involved looking at UPLIFT delivered by phone, delivered by internet, and then a control group that received treatment as usual. And in the first study, a significant treatment effect on depression-related knowledge and skills, as well as depressive symptoms, was found in people with epilepsy and depression. And from there, the originator of Project UPLIFT, Nancy Thompson, decided that it would also be important to study the efficacy of UPLIFT relative to preventing onset of a major depressive disorder. And so in that second randomized controlled trial, she was able to show significantly lower onset of major depressive disorder in the 2 treatment conditions, the phone and the web-based, as well as increases in knowledge and skills and life satisfaction. And then also importantly, I think Dr. Thompson led a third study that really sought to analyze the treatment effect on seizure frequency and severity, and found that there is a significant negative direct relationship between the treatment condition, meaning getting UPLIFT, and seizure frequency. So folks in the treatment condition of the study had a seizure reduction, whereas the individuals in the treatment as usual arm had an increase in their seizures. And the other thing that was found in that study is that perceived seizure severity was mediated and improved by changes in depression. Next slide, please. In terms of UPLIFT as an innovative program, we really think that it's both acceptable in terms of uptake with patients, that exercises are functional and practical based on feedback we've received from participants, that participants value the program in terms of the skills that they learn, and that they felt that it helped them more than antidepressant medication, and that the complexity is at a reasonable level. Deciding to participate can involve something as simple as a telephone conference. It is important to be mindful of perceived difficulties that participants may have, both in terms of physically accessing phones if there's concomitant physical disability, as well as any feelings of pressure or guilt for taking the time out. And so those are things that we've tried to pay attention to as we disseminate the program. Next slide, please. And I know Elaine will talk a little bit more about training towards the end of our discussion, but I want to highlight here that at present time, we have trainees trained in UPLIFT in 33 states. We do have a gap between the number of trainees and the number of active programs, though. We have active programs in 6 states. And so this is my platform to plea for any interested individuals to reach out and connect for training. Next slide, please. So in terms of what training involves, it's done by the Project UPLIFT team, and we can really deliver this over 5 weeks in 2-hour blocks or 10 weeks in 1-hour blocks. Either way you slice it, it's a 10-hour training commitment. The training is group and experience-based, so we do need a minimum group size in order to hold the training. And trainees preferably are licensed providers, and I can talk some about the nuances around that if it's important for this audience. And I'll turn things over to Dr. Sajatovic.
Thank you, Erica. So we are, I know, coming down the slide here with time, so I'm going to try and be relatively brief and tell you about our SMART program, the self-management support for people with epilepsy. Can I get the next slide? So this was a program developed in collaboration with our partners in the Northeast Ohio region. We focused on people with epilepsy who have a history of negative health events, or NHEs is our acronym. What do we mean by that? So this concept of negative health events came up as we were interested in trying to come up with or test an evidence-based approach. Many research studies look at health resource utilization as an outcome, but we were concerned that that might sort of obscure the potential benefit of the program. So let's say somebody has epilepsy and maybe, they're not doing well, their seizures aren't controlled well, or they're just, kind of isolated and stigmatized. They may not get health care that they need. They might not go to the dentist, they might not get their, regular physicals. And so actually when they get better, what you might in fact see is an increase in health resource use. So the reason we picked negative health events is that these are things that I think most people would agree are bad, not things we want to happen to anybody. So a negative health was defined as having a seizure, having to go to the emergency room, having to go to the hospital, having a self-harm attempt, or having an accident, related to a seizure or to epilepsy. So, any of those things, I think we can all agree are not desirable. And that was our primary outcome in our original randomized controlled trial. SMART is an 8-format session. It's delivered entirely remotely. So it's either, ideally it's web-based. We used posters and graphics and emphasize interactive discussion. So these are web-based groups, kind of like we are all doing here with this webinar. The difference is because they're relatively small groups, somewhere usually between 6 and 12 people, folks can see each other, they can interact in real time. We do have telephone call-in available for those who have limited web access or familiarity, so that's some options. The group sessions are generally about 60 to 90 minutes. They're completed over an 8-week curriculum. Our curriculum is fairly detailed. It's semi-scripted. The groups are co-led by a nurse. Doesn't have to be an epilepsy care nurse. Actually, we kind of look for nurses who like, teaching and education, and a peer educator who's been trained to deliver the SMART program. Can I get the next slide? These are the topic areas of the content that we cover in SMART. So there's each of these is chunked up, so the relationship between epilepsy and stress, for instance. We talk about stigma and double stigma. What double stigma means is if you have epilepsy plus a mental health condition, and one of our peer educators, I think, expressed it most beautifully, is that having stigma related to epilepsy and stigma related to depression, actually, this is a situation where often 2 + 2 equals a lot more than 4. So you can see the different types of topics we go through, and this is all very ripe for group interaction. Let's go to the next slide. So just to emphasize this theme that these are evidence-based approaches, our original SMART study outcome had as a primary outcome of interest was an absolute count of negative health events, so NHEs. At the end of 6 months, we compared change in reduction of NHEs in people that were randomized to SMART. So we had 60 folks randomized to SMART compared to 60 who got a 6-month wait list. And we saw that everybody had a reduction. So if you monitor people and support them, they tend to do a little bit better. But we saw that the SMART group had an 82.4% reduction in NHEs compared to wait lists that had a 59.6%. I don't want to spend too much more time on the research outcomes, but we also did show that people with epilepsy who received SMART as compared to waitlist had improvement in quality of life, improvement in functioning, a reduction in depressive symptoms. And we also recently published some longer-term outcome data to suggest that over the course of a year, people continue to have improvements, both in seizure frequency and other important life domains. I think that's my last slide. Let's go to the next one, I believe. Yes, thank you.
I will give you a short overview of HOBSCOTCH, which is Home-Based Self-Management and Cognitive Training Changes Life. Next slide. And HOBSCOTCH is a program similar to the other self-management programs that is actually focused on mainly improving cognitive problems and improving self-management around that. Next slide. Is the program component that there is some epilepsy education about what is normal regarding your cognitive problems, some self-awareness training, as well as we heavily focus on problem-solving therapy to work through your cognitive problems and your real problems in life. And then also you get taught some compensatory strategies to basically, these are little memory tricks how to kind of better remember some things. Next slide. This is the program structure. The program is also delivered over the phone. Initially, we had one in-person session, but we also have a fully virtual version of this. The patient gets assigned a memory coach, so this is one-on-one individual coaching. And initially, the patient gets introduced to the program, and then through the telephone visits, works through their memory problems and learning those strategies. And then at the end, there's a maintenance plan developed. Next slide. This is how it works. For example, you see to the right, this is how the problem-solving therapy would work. The patient would have a problem, like I'm forgetting my medication quite frequently, then has to find a goal, is not to forget the medication. And then the patients themselves have to find possible solutions that work for them, like buying a pill box or setting a reminder, or my wife needs to remind you. They need to choose a solution, and then they have to basically do homework for a week, trying this out till they check in again with a memory coach. Now we also have some app that is also in a study time will complement the program. And to the left, you see all the memory strategies patient can learn throughout that program, and they're also quite helpful for normal people, like remembering names and things like that. So next slide. These are the three domains we focus on, which is disease management, such as taking your medication, organizational skills, such as like not forgetting your grocery list when you go to the grocery store, or social skills, for example, like not remembering names and things like that. Next slide. We have also tested this in a randomized controlled trial. Next slide. And we actually could show that with HOBSCOTCH there's a significant improvement in quality of life, as well as in subjective and objective cognition, which is measured by the RI bands, as you see in the middle. And we, next slide, we did another randomized controlled trial, HOBSCOTCH 2, where we could nicely replicate the previous findings. Next slide. So we deliver training for the HOBSCOTCH coaches. So in epilepsy centers or out of community organizations, we can train memory coaches to deliver the program. You will get a certificate for that you're a trained person. You need to be a licensed healthcare provider, and if you consider, becoming a coach, you will continue to be supported to ensure fidelity by technical support calls from our team. Next slide. And this is not only, it is for all levels, as you see here. It is really helpful to go through this program. And with that, next slide. I really want to come back to COVID-19. I think it's a time now where epilepsy self-management is needed more than ever, and that we really want to support our patients who are out there. And it may be also a good time to get trained in any of these programs. Next slide. Therefore, all the academic centers that are presenting to you today have come together to kind of, is there in this emergency time some way to train people in these programs to help them through these difficult times. You can also get trained. Often we do something at the AES or AAN meeting to get trained in this program. And I would just encourage, if you're interested, to contact the respective investigators at the academic centers if you would like to establish one of these programs at your center. Next slide. And these are some concrete training times that we set up for the COVID time. So this is for certain programs. If you're interested in UPLIFT, which is geared towards depression, we have a group running from April to May, as well as for PACES, and just email these respective emails if you're interested to register in training for these programs. Next slide. And this is for HOBSCOTCH as well as for SMART. Next slide. And another possibility is just referring patients to these programs. However, there's limited capacity for us to do this all remotely. You can email just the new programs, or you can email the respective academic institution if you're interested in referring patients to certain programs. And next slide. And these are just some links where you can get more information about all of this. And I would also especially send you to the AES website for the COVID-19 resources. There are a lot of, not necessarily self-management, but a lot of good COVID-19 resources at the current time. Next slide. And we are now open for any questions.
Okay, thank you, speakers, for your presentations. We do have some questions that have come in already. I would like to remind the attendees that they can ask questions using the question and answer button as part of Zoom. We've had a few questions come up about training, and I'd like to follow up on that, add to that question as well. Are there any types of practitioners that could be trained with these programs? Is it geared for nurses, neuropsychologists, physicians even? I'd like the panelists to address that question.
Maybe we go through our respective programs, and I start off with HOBSCOTCH. In HOBSCOTCH, we have trained all levels of licensed practitioners, from nurses, social workers, psychologists, MDs, nurse practitioners. Any of those could become a HOBSCOTCH coach. And I give it over to the next program. Maybe UPLIFT and PACES, Erica.
Oops, sorry, I was off to the races answering with my mute button on. Yes, so for UPLIFT, we've trained everybody from epilepsy affiliate support staff to clinicians. The emphasis within UPLIFT is on having some level of either training yourself or backup support from a mental health provider, since these are folks who are at risk for depression. But we do train a wide variety of individuals. And with PACES, we do the same. We the mental health emphasis is present. I don't think it's quite as acute as there is with UPLIFT. We get folks who have a wide variety of concerns around mood, but certainly comfort with group facilitation is something to think about, and something that we emphasize in training. Bob, did you want to say more about PACEs?
Just that we need the peer facilitator with a disability. So in a number of cases, we get interest from centers, but they can't come up with a co-facilitator with a disability, and that's an important component of our program.
Yeah, and so to add to that, that's, you know, typically a patient who's pretty well adjusted, comfortable with their own, you know, their own epilepsy situation, and able to kind of to relate with people about their individual experiences as well. And sometimes the local EF affiliate can be really helpful for identifying peer facilitators.
So this is Martha. Let me jump in with SMART. SMART, we have predominantly been using nurses. We could definitely consider other healthcare providers. We'd like somebody with a little bit of a medical background, ideally, but certainly doesn't have to be epilepsy. And then I agree, Bob, that the peer educators are really critical. Our training for SMART does involve training of both the peer educators and the nurse educators. We train them together so they can support each other. We actually don't sort of advertise or focus that we need to have a peer educator that's particularly skilled. It's always been our premise that we learn more from our mistakes sometimes than from our successes. And so talking about, you know, how sometimes things didn't go the way you wanted to, and how you might be able to use self-management to make it better is really a critical part of our learning. I did want to just point out there was a slight clarification that I wanted to make for the SMART training on one of the slides. Is we probably are going to be pushing this to a May date, but we may be able to take some referrals beyond the state of Ohio, both for patient referrals as well as for those who are interested in getting SMART training. So the contact there for Carrie Zimmerman is the one that, you know, if you want to hear more about SMART and upcoming training opportunities, please feel free to reach out, and we look forward to hearing from you.
Thank you. There's been some questions about, are these programs available for adolescents or pediatric patients or parents of pediatric patients with epilepsy?
So I'll answer that. None of those programs has been tested in the pediatric population so far. There is, so we don't have it set up really for the pediatric population, or there had been a program, UPLIFT for caregivers, I think. Maybe Erica, do you know more about that?
Just that there has been one developed for caregivers, yes. So for parents or other caregivers.
Yes. So.
I have a few questions of my own that I will ask as well. Any tips or tricks in identifying particular patients that might benefit from these programs? Obviously, not all patients might be open or willing to consider this type of program. Any tips for screening patients or identifying patients that might benefit from
Actually, David, I'd like to just quickly address that with some of the data that we have with SMART. We did an analysis looking at people's educational levels and health literacy and, you know, race and ethnicity, at least with SMART, and found out that really just about anybody can benefit. Even people with very low levels of health literacy. We did find that folks who had a little more education might achieve greater gains, but the way I would take that is that, you know, I really can't think of anybody who would not be a good candidate. It's, you know, even if you might not focus on seizure frequency, but you can certainly, we can all probably try to improve our quality of life and, you know, ability to manage epilepsy.
Just out of practical, like having run those studies, it is fairly clear when you offer it to the patient who is interested and who is not interested. So that is like one way how you can find out who will benefit from them. We have had experiences that if just the spouse is interested and the patients themselves not, that is not a good idea. They often kind of drop out of the study or something like that.
Okay.
This is Elaine. I'm sorry. There is the possibility of having someone go through the program with caregiver support if there's an issue with being able to get through the program on their own or just needing some help with sort of understanding the concepts. We have successfully been able to pass people through with the support of a caregiver in their home for HOBSCOTCH, particularly where it's one-on-one. It's quite easy to work together with a coupling like that.
This is Bob. For us, the cognitive level is an important consideration. Someone with kind of low average intellectual functioning without marked memory problems, benefits more. And our doctors in recommendation, it's kind of interesting. They refer people who show up for their medical appointments, feeling that they'd be more tenacious in staying with the program.
Following up on that, there's a question that came up about any recommendations about how to go about putting these programs and screening for patients into a standard workflow in clinical practice.
So I can take this, that like we in our clinic, we screen patients for depression as well as for cognitive problems. So we do something close to the PHQ-9, the NITI, and also from the quality of life scale, we ask about cognitive problems, and then if those are positive, then like if the cognitive problem is more of the problem, then we refer them to HOBSCOTCH, and it may be a possibility if they screen for depressive symptoms and something like UPLIFT may be helpful. And PACES kind of covers all of these things, so it's really tailored a little to the patient.
Barbara, I would just like to make a comment, this is Martha, that not all these programs necessarily have to be intrinsically linked to the clinical workflow. We are, our local epilepsy association is offering SMART in the community, so people can self-refer, families can refer, and it could be an adjunct program in addition to standard clinical care, which of course we do support people in trying to optimize what they get out of their standard clinical care as well.
Excellent point, Martha.
There's been several questions about utilizing these programs outside the US or having translated into other languages. In particular, someone asked about Portuguese.
So far, we have a Spanish version of UPLIFT, and I think, Erica, you're working on a Hispanic version of PACES. Mm-hmm. But we don't have anything in Portuguese. So currently we don't have anything, but we are always open to new opportunities.
Our co-investigator at the University of Texas Southwest speaks Portuguese, so we might bring that up with him.
Okay. A question came up about, in contrast to UPLIFT, would HOBSCOTCH be more geared to lower functioning patients?
They address, the emphasis is different. You know, HOBSCOTCH is really aimed at cognitive remediation, cognitive compensation. So compensating for memory issues, that kind of thing. Whereas UPLIFT is very much focused on mood, on depression. There has been some concern with UPLIFT about is mindfulness practice too kind of abstract for certain groups, and there's been a real effort on the program's part to bring on board applications and examples and exercises that are more concrete in nature.
Okay.
Barbara, did you want to add anything else to that?
Yeah, I want to second this, what you're saying. It's not that we recommend only doing hopscotch in this population or that population. They can base it, as it's very patient specific in hopscotch, kind of everybody can benefit because you work with your individual coach, what is within your capabilities.
Unfortunately, we do have to end the call now because our AES staff need to be on another call at this time. On behalf of AES, I want to thank everyone for your participation in today's event. Please note that the recording will be made available on the AVS COVID-19 Resource Library within 7 to 10 days. This concludes today's presentation.
Thank you, everybody.
Thank you.
Thank you.